clearly? Hello, Assalamu alaikum. Can you hear me?
Yes, perfect.
Yes,
Go ahead,
okay,
please.
very well. So today we're going to talk about bleeding management and coagulation monitoring during liver surgery. I will try to share with you my experience in this field, and we'll go through the steps in how this part of analysis became quite important for our clinical practice. Bismillah ar-Rahman ar-Rahim. This is our Menofia University, and this is our old liver institute, and beside it the new...
Khaled, I'm sorry for interruption. Yes. We cannot see your presentation. We cannot see the presentation. If you share screen, please.
See the presentation. Okay, so let me go back. Where are we? Okay, here we are. Can you see the presentation now?
Perfect. Okay, if you press play, yeah.
Can you see it now?
Yes, Prof. Khaled.
Okay, shall I continue? Okay, Bismillah ar-Rahman.
If you just make play of the presentation, because we see the full presentation, the full PowerPoint.
You want the full screen?
Yeah.
Well, I have something.
There's a message. There is a message. If you press dismiss, perfect.
Yeah. In a message? Is that okay?
I can see a blank white screen in front of me now.
Okay, wait a minute. Yeah, now?
Yeah, perfect. Okay. That's fantastic.
Okay.
Now. Thank you.
So starting again, this is the bleeding management and coagulation monitoring during liver surgery. This is the lecture. Bismillah ar-Rahman ar-Rahim. This is our National Liver Institute, the old building and the new building. Here I have really to, importantly, to say that Professor Magdi Khalil has a lot to do with the new building. And we have to really to thank him for his efforts to erect up this new building with about 430 beds and a big ICU and OR rooms. The objectives of this lecture is to speak about our experience in Egypt and the world concerning ROTEM as a monitor and how it is used to guide blood transfusion and coagulation medications. These days, we have coagulation medications. We have ampoules for fibrinogen. We have ampoules for prothrombin complex concentrates. And we will go through the research from our National Liver Institute. I have here to represent my conflict of interest. And I have to acknowledge Professor Klaus Gorlinger for his assistance in preparing this slides. And joining us in several research projects between Egypt and now between Saudi Arabia and Germany. This is the type of liver that we are all working through and anesthetizing patients with liver cirrhosis. As we all know that hepatitis C is one of the main causes of liver cirrhosis in Egypt and in the Middle East. But it is now decreasing in incidence with the very wide nationwide program of detecting hepatitis C in Egypt and using advanced antiviral medications. This is type of surgeries that we do during liver resection or in donor livers. We can split the liver into two pieces. We can remove the left lobe, the right lobe, and we have to do this in cirrhotic tissues, which is quite different from in the Western world. In the Western world, liver resection is done on a background of a healthy liver cells. But in our Middle East zone region, and particularly in Egypt, it's done in a background of a cirrhotic liver. Here, blood loss is more. Here, coagulation problems have to be tackled accurately. In order to do this, we've started using viscoelastic tests. This is one of the advanced apparatuses for this. It's called ROTEM. And they also have another ROTEM Delta, and they also have another more advanced called ROTEM Sigma. But this ROTEM delta is very important because it can measure the platelet activity as well as the coagulation factors in the blood. What is this ROTEM? It is called, R is for rotational thromboelastometry. So it measures the viscosity and the elasticity of a clot formation. And it will specifically tell you what and where is the problem in the clotting process. Is it due to excess heparin? Is it due to fibrinolysis? Is it due to platelet hypofunction? It's very important. And not less to tell you that these days during the COVID-19 pandemic, ROTEM role in saving lives of patients is now becoming more significant. And they are starting to realize how through ROTEM we can diagnose hypercoagulation and even hypocoagulation in COVID-19. But this will be a separate topic, and we are preparing a review about this topic, and hopefully we will be published soon. What is the diagram that we get out? We get out a beautiful diagram like a fish-like diagram, and it gives you through its parameters. As you see, we have in green the clotting time, and this clotting time has a normal range. If it is prolonged, means that we have a problem in the clotting factors, and we need to give fresh frozen plasma. But if the one in blue, MCF, is thick and the graph is big, then we have hypercoagulation. But if it is a thin graph and a low MCF, maximum clotting firmness in blue, then this means we have hypocoagulation. In this instance, we have to contact the blood bank and ask for platelets or cryoprecipitate. And nowadays, why do we need cryoprecipitate? Because cryoprecipitate is rich in fibrinogen. Why do we need platelets? Because platelets is very important for the blue, the maximum clot firms. So we will not order fresh frozen plasma, for example. Cryoprecipitate contains fibrinogen, and these days fibrinogen is now produced as ampoules. We can use it as ampoules as well. We can see now in black maximum lysis, which shows and indicates that this clot, if it is abnormal, this clot is suffering from fibrinolysis. And in this instance, the treatment is anti-fibrinolytic agents as tranexamic acid. Let's go through the slides and we will see the defects when we go one by one. What is the importance of this ROTEM? It is going to help us during surgery to know if the bleeding is from surgical reason or it is due to coagulopathy. The European Society produced its own guidelines from the European Society of Anaesthesiology, and it was published. And one of the most important authors in this is called she's a female doctor, Zibla Kozak. She's from Austria, and she did a lot of work in producing these guidelines. These guidelines from the European Society relies very much on recommending transfusion through viscoelastic tests like ROTEM. Also, the American Society of Anesthesiology Task Force on Perioperative Blood Management created their own guidelines and implemented that these guidelines should be followed in any trauma case or in hemorrhage. And they said that during intraoperative and post-operative interventions, it is important to monitor platelet functions, viscoelastic hemostatic assays, and there is two types of viscoelastic hemostatic assays, one called TEG and the other one is called ROTEM. TEG and ROTEM, actually the same, are doing the same job, but their technology are a bit different. There is now also something new coming up, depending on dry reagents, but it is a third company producing another viscoelastic hemostatic assay. So the American Society recommends monitoring blood coagulation with ROTEM or with TEG or with viscoelastic test. The practical guidelines for perioperative blood management in the American Society of Anesthesiology depends on not giving pharmacological treatments unless it is indicated from the ROTEM trace or graphs, like antifibrinolytic agents, like tranexamic acid. And in the bottom of the picture, you can see the PCC, which is the abbreviation of prothrombin complex concentrate. Nowadays, instead of giving fresh frozen plasma, which we give when we have a prolonged clotting time, fresh frozen plasma need to be ordered from the blood bank, and you have to order it in advance to have it immediately in the OR time. It might take some time to come to you in trauma situations, but nowadays it's been replaced by prothrombin complex concentrate ampoules, which we store in the fridge. In Montefiore University, in the National Liver Institute, we had for some time, but with a special import, because it is now becoming, just maybe this year, becoming illegal to use it in Egypt. We have a stock of prothrombin complex concentrate and fibrinogen, which we can use to interfere immediately if we find during bleeding, during transplant, that we are in need for it. The Journal of Trauma and 2014 Consensus Conference on Viscoelastic Tests produced their own guidelines. And as you can see, we have several graphs and figures of the ROTEM. In the first graph, called XTEM, which measures the extrinsic pathway, and in the last graph where you can see fibrinolysis, this is when it is indicated to give anti-fibrinolytic agents like fibrinolysis. If you see this picture, this is a strong indication that we should give tranexamic acid. So ROTEM and bleeding management in hepatic patients, how did the monitoring of coagulation parameters affect our management of hepatic patients? It managed to reduce both bleeding and thrombotic events, and as published by Klaus Gorlinger in his book, it reduced both bleeding and thrombotic events. In acute gastrointestinal bleeding, like in varices, esophageal varices, restrictive transfusion strategy helped to reduce portal hypertension and transfusion-associated overload. Also, in hepatic patients who are going to be prepared to undergo invasive interventions, like endoscopies, for example, using ROTEM did reduce the prophylactic use of blood before these interventions. This is a very nice picture of fibrinolysis. As you see, the fibrinolysis here, and its treatment, as we said, is tranexamic acid. We go, my story started with ROTEM in 1991 when I was in England, in Leeds, preparing for my MD thesis. At the same time that Professor Magdi Khalil was working on muscle relaxants in Paris, or in Paris, en français. Dr. Magdi Khalil speaks very good French. And in fact, we both left Egypt almost on the same time. They were preparing us for the coming up liver transplant program in Egypt, which was one of the first in the Middle East. My protocol was surprisingly on tranexamic acid use in liver transplant. And it was published in the Clinical Transplant. And we managed at that time, when liver transplantation was cadaveric and it was in Leeds and it was at the beginning phases, there was a lot of blood loss there. And we used to use veno-venous bypass. When we started using tranexamic acid during the liver transplant prophylactically, it reduced the blood transfusion. So we go to the next slide. What is happening today? We are not using tranexamic acid prophylactically these days in liver transplant. We are using it today guided with ROTEM grafts. And this is based on many observations in that not all the patients are similar. If you give tranexamic acid to every patient, and this is, you should take in consideration when doing non-transplant cases, because some of these patients have genetic hypercoagulation. Some of these patients might react abnormally to tranexamic acid. So you must find true evidence of fibrinolysis on the rotational thromboelastometry prior to ordering or administering antifibrinolytic agents. Klaus Gorlinger presented a very good article in 2006. We continue with our research. This is the picture of Dr. Maha Lotfi. She did a very good work on her MD thesis between Cairo University and Menifee University in the period between 2009 and 2013. She went abroad and presented her work. She did her work in a group of volunteers who are donating half of their livers. And at that time, there was a big row that these patients or these donors, volunteers who are very important because they are not patients and they are going in to donate part of their liver to their family relatives. There was a talk that on the 10th day post-surgery, these patients, there was some reported case presentations that they develop deep vein thrombosis because they become hypercoagulable. So we decided to study this in a thesis, an MD thesis, presented in Spain during the International Congress for Liver Transplant Society, and it was published as an abstract in the Liver Transplant Journal. We proved that there was no hypercoagulation in the group study, and that there was no even hypocoagulability. Despite the hypocoagulability, you could detect in INR and prothrombin time, but it was safe to provide these patients with epidural analgesics. But we actually found something significant, that the ROTEM studies and parameters were not in good relationship with standard coagulation tests. ROTEM is giving us something, and these coagulation tests are giving us something. Maybe Dr. Magdi Khalil will recall what he taught us, that sometimes you see liver patients coming in with high INR, and then you realize that they have portal vein thrombosis. How come they thrombose and they have high INR? Here we learned here that INR and active partial thromboplastin time and standard coagulation time represent ex vivo studies. They don't represent actually the whole blood clot picture. They represent the plasma without platelets, without RBCs. They represent the blood sample after centrifuge. But rotational thromboelastometry and TEG and other viscoelastic tests will represent the whole blood as a whole in the coagulation process. And here we learned that there is no significant correlation between ROTEM and other standard tests. The study was very good. It was cited 4 times in PubMed. This is recently, and many times in other non-PubMed citations, and it was part of a textbook in London. Ahmed Badawi from Damanhur, and he was from Alexandria resident, and he's now working in Helwan University as a lecturer, did his MD thesis with us, with Alexandria and Menifee University, and came up with the same, but he did it not among donors. He did it among cirrhotic patients suffering from hepatitis C, who are subjected or scheduled for liver resection to remove a tumor. He found that ROTEM is not in a good relationship with prothrombin time or clotting time. And this was published in the Journal of Anaesthesia. A lot of work have been done on donors, and I had the privilege to have my first chapter published in the University College, King's College Hospital. This is out on market this month in London, and in it we put all this research, and in it we put our understanding of how to manage anesthesia for live donor hepatectomy. In it, we included our conclusions of those two important researchers by Maha and Ahmed Bidi. ROTEM as a coagulopathy therapy. What can ROTEM help us to do? It can predict. We can use ROTEM to predict if this patient is going to bleed or not, to predict if this liver transplant patient is in a good state to go through liver transplantation, or he is very bad and suffering from severe coagulation problems and would require specific measures. This was published in a nice research by Nermin Fayet, who is working currently as a consultant in Dresden in Germany. She did a very good work, and she did present a very good couple of papers, 2 or 3, talking about how ROTEM can be a very good predictive for bleeding intraoperative. I recall one of those papers was done with Professor Magdi Khalil, and we will go through it in the next few slides. So preoperative thromboelastogram can help us detect and distinguish patients who will bleed. And here I can recall a case during my work in Cairo Liver Institute. Before we do liver transplants, we do a baseline liver ROTEM study or parameters, and have a look at it just to make sure that our patient is not bad. In this patient, we could detect severe fibrinolysis before we touch him, before we put central lines in and big invasive lines. And that patient was treated with tranexamic acid prior to the anesthesia induction. And he went through the surgery with very minimal blood transfusion. And thank God that we have a rotational thromboelastometry that could predict fibrinolysis. While when you look at the standard coagulation tests, including D-dimers, FDPs, none of this could be released. None of this could tell us something that we are facing a severe fibrinolytic situation. This paper was published or cited 8 times in the PubMed Central articles, and this shows the importance that these people, these data was important for other researchers. We have to say something very important. Why am I going back? Oh, it should go in for, okay, here we have to say something very important. We should encourage research wherever your field is. If you're doing cardiac surgery, if you're doing day surgery, even if you're doing kidney transplants, if you're in neurosurgery, research is the base of all textbooks. Research is what we owe to the level we reach today. Every consultant should have at least one research project a year where he can present his experience through it. And, here comes Dr. Magdi Khalil. In 2011, we started, because our cases were very difficult in the Liver Institute, we have hepatitis C more, and it was aggressive. So we started using prophylactic low dose of recombinant activator factor 7. And we found significantly good results. He used, Dr. Magdi had this idea of using 20 micrograms per kg, which at that time showed us a significant improvement in the coagulation parameters. 4% of our patients in control did not receive blood, while 36% in the Novo 7 group did not receive any blood transfusion. and 24 received only packed RBC. So we, for the first time, we started to know that there is something called transfusion-free liver transplant. That was published in 2012 in Anesthesia and Clinical Research. It was cited 8 times as well. And this is a nice diagram showing that in 2013, this was our blood transfusion. 100% of our patients have blood. Look at the no transfusion started to increase in 2007 and started to be in 2009, 43 cases, 33%, and 36 and 40% by 2013. So this protocol of using recombinant factor 7 was quite valuable. Plasma transfusion was reduced. But with the getting more in the studies and work, and with ROTEM becoming more available in our OR, we started reducing the amount of recombinant factor and not using it unless we feel that we have signs of coagulopathy on our ROTEM. So instead of using it prophylactically, we started using it with a ROTEM-guided algorithm, as presented in many international studies like Haas and Klaus Görling. This is a picture of another colleague, Shireen Dawood. She is a MD, a researcher from the Ministry of Health in Cairo. Dr. Shireen did her MD thesis about monitoring and detecting heparin during liver transplant. We all know that heparin can be secreted endogenously, so we call it heparinoids. These heparin can do a great destruction and trauma to our liver transplant patients. And we could face problems with it if it goes unmonitored. We don't know the extent of this heparin-like effect, so we started this protocol study, perioperative heparinase rotational thromboelastometry monitoring during and after living-related liver transplant. Here in the graphs, as you can see in the first graph, we look at the CT. CT reads in the circle red. It reads 400, almost 500 seconds. It is very prolonged. But when we give heparin, it is reduced. So this is a very simple test that tells us that this patient is suffering from heparin-like effect. It is very difficult to imagine during liver transplantation that we could give protamine sulfate, but like we used to do in cardiac surgery. And nowadays, even cardiac surgery in cardiopulmonary bypass surgeries, they are monitoring their heparin-like effects and the doses that they give to reverse protamine with ROTEM. They started doing a lot of studies in which they can tailor the amount of protamine they are going to give to reverse the heparin-like effect that they use during bypass. In liver transplant, that was unusual. But we only locate it or treat it if it is seriously affecting the bleeding. And we could recall case presentations worldwide about it. One was in pediatric liver transplant in Brazil, and the other one, for me, myself, I used it in one of the liver transplant cases in which it bled severely after reperfusion. And only was this patient rescued when we decided for the first time in maybe Egypt, I don't know other centers, but for me in Egypt and even in Saudi Arabia and even in UK, where I did liver transplant, we never used protamine, but here I was actually encouraged to use it because I could find evidence of heparin-like effect in the ROTEM trace. I could see it clearly in a prolonged CT that is reversed by heparinase, very clear. And the patient The surgeons cannot stop the bleeding, and the patient is bleeding massively. We gave the protamine in this case, and the patient survived. So this shows you how important. How could we know without rotational thromboelastometry that this patient is in need for protamine? If we do not measure the traces of protam, we will actually give him fresh frozen plasma, cryo, and I don't think this patient would have survived. But when we were able to locate the problem of heparin-like effects, we could then encourage ourselves to use protamine, which we don't often use it. This research was presented in Copenhagen, or as they call it in Denmark, Copenhagen. It presented in 2018, and it shows this is the phases of liver transplant: preoperative, anhepatic, and reperfusion. Most commonly, we find heparin-like effect in the reperfusion, after reperfusion, and it subsides automatically on its own. It comes in for 5-10 minutes, half an hour, and then it subsides. By the first day and second day, you can see in the yellow colors, we could find some traces of it. But what was important in this research is the severity of heparin-like effect, the ones in red. The patients who suffered from a severe heparin-like effect during reperfusion was those who suffered from high rates of mortality. This was a discriminator for us and could discriminate patients who will need serious attention because they are going to suffer from high complications. This is called severe heparin-like effect. So we produced a ratio for this heparin-like effect depending on the parameters that we get from ROTEM, and we could say that if this ratio is more than 2, then this patient suffers from a severe effect. These are the 2 cases where protamine was used. One was published in the Pediatric Transplantation Journal in 2009, and the other one was included in a Gorlinger textbook about protamine overdose can prolong coagulation times. In that we should, when we give protamine in liver transplant patients, be careful and give it in reduced dose because it is itself can lead to prolongation in the clotting times. Now, as we mentioned before, new coagulation management drugs are available these days. We have fibrinogen concentrates. It comes in 1 gram ampoule from Hemicompletan company, and PCC, prothrombin complex concentrate. This first one, fibrinogen, replaces cryoprecipitate. The second one can replace fresh frozen plasma. So cryoprecipitate, we all know 1 unit contains 300 milligram fibrinogen. You have to order it from the blood bank, and it has only 3 to 4 days half-life. The other one, fibrinogen, it has 1 gram. You can put it in the fridge and becomes available at the time you need it. It is available in Europe, but its entrance in the Middle East started to enter in few centers in Egypt and in few centers in Saudi Arabia. I could see it also in Kuwait and in Emirates. So we have to have these ampoules standby in our OR, in the fridge, because it can save trauma patients, it can save any patient bleeding where you will diagnose a problem that indicate the use of these ampoules. So I try to mention them here because we should really be familiar with these ampoules, which are starting to be part of our coagulation management in ICU even and in OR. In Switzerland, in 2017, We had one of our colleagues called Yasmin Kamal, Yasmin Abdesalam from Liver Institute. She monitored patients with ROTEM whom she thinks they have hypercoagulation. This was the first time. You see, when we talk about ROTEM studies, most of the ROTEM studies are talking about hypocoagulation. Very few are talking about hypercoagulation. This study was used as a pillar for COVID-19 because very few studies were done about utilizing the ROTEM to monitor hypercoagulation. We realized during our OR liver transplant that some patients develop hepatic artery thrombosis. Others don't, despite we are using the same guidelines. It came to our knowledge that these patients might suffer from genetic or acquired tendency to hypercoagulate. So we studied these group of patients in which we thought they have genetic and acquired, and we came up with important topics or conclusions. And this was published in a very important journal in Germany called Transfusion Medicine and Hemotherapy. And these guys in the transfusion medicine, the reviewers and the editors, had to contact us and contact Klaus Gorlinger to make sure that this data is okay, because it was the first time to present hypercoagulation. Am I running short of time, Dr. Walid? Am I okay?
That's 40 minutes now, I think, yeah.
Yeah, I'm going to conclude in less than 5 minutes. Okay. So we found signs of hypercoagulation in FIBTEM, and this is, as you see, it becomes hypercoagulation at 7 days post-operative. We did another study, and we found that there is, by Hisham Gamal, and we found that there is genetic, and that was a discovery. In liver patients in our institute, we found that 52% have genetic mutations that we should take care of in the next few studies. One of the last things that we need to mention in ROTEM is that we could measure the platelet functions. Platelet functions is very important to ROTEM, and that was an addition to it. And as you see in the lower two graphs, we could see the platelet activity. If it is low, then it becomes better with liver transplantation. This is Dr. Iman. She presented a very good topic about monitoring platelet functions for 3 weeks in liver transplant, was presented in the anesthesiology meeting in the States in San Francisco. And she found significant, important, hyper increase in platelet functions after 2 weeks of transplant. 2 weeks of transplant, we have hyperactivity of platelet functions in which can lead to hepatic artery thrombosis. And this is the first time that liver transplant anesthetist role expands to 3 weeks after transplant. Make sure that this hyperactivity of platelets need to be put under control. I conclude with this latest textbook, which will be published in the States in Texas University, sometimes next few months, and will include all these past 10 researches that we presented from Menofia Liver Institute. Thank you very much. Thank you for the teamwork, all the members in Liver Institute and the National Liver Institute. Thank you, Dr. Magdi Khalil. Thank you, Walid and Dr. Tharud, for allowing us this opportunity to present a topic about coagulation monitoring in liver transplant and how important it is. Thank you.
Thank you, Khalid, for this illustrating presentation. I know to understand hemostasis and coagulation, it is not a one-way journey. It is a to and fro, where something you might be treating for coagulation might be go to bleeding and so on. So I know you simplified the subject very, very much. And I just declare to you that most of our candidates in the Liver Institute are attending the presentation, which is more to enforce our experience with that. I have some good data, just completing the effort of your colleague in the Liver Institute, that Iman Awad is going now, and all her colleague going to present something about the importance of ROTEM in COVID.
Yeah, very good. Yeah.
Okay. Now a question from, I don't know what is the question. No question up to now. I think Walid, you asked Muhammad for Fuad. If I just chat. What about ROTEM for COVID? Okay. You have some thing to
Yes, yeah. Would you like me to answer this question? Yes. ROTEM is very important in COVID. And these days, they are starting to use ROTEM to monitor COVID patients and detect their hypercoagulability. And they found something very interesting in COVID patients, in which these patients are resistant to fibrinolysis. They don't want to break. And that was one of the main reasons of hypercoagulation among COVID patients. We are writing a review article these days, and we're in the process of publication, in which COVID-19 patients suffers from fibrinolysis shutdown or hypofibrinolysis, and they are indicated for fibrinolytic therapy. They are using tissue plasminogen activator to break down the clots, but recently we've noticed something very important. You mentioned Dr. Iman Awad in Menifee University, and another colleagues in Beni Suef University. They presented that inhalational streptokinase could be used to give a local effect in the microcirculation in the alveoli. It breaks down the fibrin, it breaks down and clears the alveoli, and very promising results are coming in from antifibrinolytic treatment for COVID-19 patients.
Just another question also from Muhammad Salim. He asked a question. I think this is a major question asked by many about number one, what is the difference between ROTEM and TEG?
Yes, there is ROTEM. The difference is in the technology. In ROTEM, the cup does not rotate, but instead the pin rotates. So it's basically a technology and reagents difference. In TEG, the cup rotates, the cup that contains the blood. So it is a technological difference. ROTEM and TEG are actually the same. ROTEM and TEG are doing the same job.
Another question also from Muhammad Salim. Visioelectric tests are long-time tests. It have a role in emergency situation?
This is a very good question. Because ROTEM tests are a long time, it can take maybe 10, 20 minutes, 30 to have a full trace. But nowadays, they have a 5-minute parameters, normal reference ranges. And it comes up on the computer of the monitor, and you can, in less than 5 minutes, have a result. Plus, what is the length of the time for you to send to the laboratory and receive standard coagulation tests? ROTEM is faster. 5 minutes is more than enough.
Muhammad Mad is also asking the last question: is neuroaxial block contraindicated with antiplatelets?
Is neuroaxial? I leave that to you, Dr. Mad. You are an expert in this.
No. This is beyond the scope of ROTEM, but normally the French guidelines of surgeons prohibit using neurosurgery that might be extrapolated to spinal anesthesia if the platelet is less than 80,000. And if the patient, now we have many antiplatelets. According to the half-life, if the effect of the operation is included in the half-life of antiplatelet, so it is contraindicated, at least medically. Okay, I think now another question. Hani Abdel Galil, if a trauma patient received Wolverine for a station, it can affect the ROTEM results?
Dextran affects it, but for Volven, I don't think, but usually we're using these days 5% albumin more. Volven can affect, but it needs more studies. There are controversial data about this.
Also, another question from Mohammed Salim. Do you support the use of prophylactic use of antifibrinolytic drugs in cardiac and spinal surgery?
As we said, we're not going to give anything blind anymore. We are going to give it based on findings that you see in ROTEM. The only thing that you give blinded tranexamic acid is when you have a severe trauma case coming in the OR, in the ER room. This is the only thing.
Do we need to do routine ROTEM for all patients, or we monitor the patient if bleeding starts?
Not for every patient, because it is expensive. We will monitor the bleeding status, but in liver transplant, we have to do it routinely for every patient.
Last question from Mohammed Salim. What is the value of Novo-7 in pediatric patients?
I have no information about this. Maybe Dr. Magdi knows.
No, it was, actually speaking, if transplanted, previously the first indication was hemophilia, which is given to a pediatric patient. But we are still a little bit afraid from the small size of the hepatic artery, so might be deleterious. As you said, there is no research work about that, but from theoretical extrapolated to our patient, it could be used. Thank you, Professor Khalid, and I wish I see you again in Liver Institute.
Thank you, Dr. Magdi Khalil. All my regards to our colleagues in Menifee University National Liver Institute, to my colleagues in Egypt, and all over the world, because I know these webinars are watched everywhere. I can see the data, Dr. Walid. You're doing a great job, Dr.
May I have a question myself, please, if you allow me?
Yes, please.
The question beyond the is not free. You have to pay it. You have to pay for Dr. Khalid.
That's fine. Okay, so in order to ask my question, allow me to share this screen for a few seconds. Can you see my screen, Prof. Khalid?
Yes.
Perfect. So this is what we do in our institute in the Mater University Hospital in bleeding patients. And this is the approach we do. And I need just to make it simple, and you correct me if there is any mistake in our approach. So, this is a simple ROTEM, FIBTEM, XTEM, INTEM, and HEPTEM. We look at the top two only, which is a FIBTEM and XTEM. And we are trying to make it as simple as possible for all juniors. So we look at the A10 in the FIBTEM, and the normal here is more than 8. And if this normal more than 8 is impaired, I mean, if it's less than 8, we give fibrinogen 4 grams. And then the second step in our approach is to look at the clotting time in the X10. And the normal is less than 90. And if it is prolonged and more than 90, we give plasma 2 to 4 units. And the next and the third step here is the A10 in the X10. And the normal is more than 35. And if it is less than 35, this is the time to give a pool of platelets and then repeat the ROTEM and see again our approach, how it worked. This is what we do. I will leave it here for yourself to correct me if this approach is, I think it is very simple and very approachable to the junior trainees if they have a facility of the ROTEM to approach. We don't look at the HEPTEM at all or the INTEM at all in post-cardiac surgery or in trauma or wherever we are managing bleeding. What do you think about this approach? You are the expert in this field, and I want to make use really of your experience here. Do you agree on this approach?
This approach is very reasonable, especially that you're using the 10 minutes, and this will give you a rapid effect. And it's very important that you are teaching the junior staff the importance of ROTEM. Nowadays, we're also teaching it in the final year's medical students, and it is available everywhere. Yes, 10 minutes is very good. But of course, XTEM and FIBTEM will give you a very good idea. HEPTEM, you don't need it unless you have a problem like heparinoids that is secreted in liver, or unless you have a serious coagulopathy situation which is not responding to the usual measures. So you have to look for reasons. So you will have to measure the heptem and see if you have heparin-like effect. So this is not usual to do. The INTEM, you use it if you want to measure intrinsic pathways, because this one represents the intrinsic pathways. Usually we do the 3. To be very clear, in Germany, they do XTEM, INTEM, and FIPTEM, the 3. Because if you do XTEM only, then you will miss the intrinsic pathway.
Perfect.
So I would encourage you to add the INTEM to your... Yeah.
Perfect. Yes, yeah, I agree. Very good. So thanks very much, and I will stop my share here now.
It's very great that you have ROTEM in your hospital. Thank you.
Perfect. So any more questions, Prof. Magdi, before we proceed to the next session? Okay, so thanks very much for Professor Magdi Khalil for moderating this session. Thanks very much to Professor Khalid Yassin for the fantastic presentation. And I think we are going to next lecture now with Dr. Tharwat Isa. I know Dr. Tharwat Isa for a long time, around 20 years. And Dr. Tharwat Isa worked with me during the residency training program in Tanta University Hospital. He got the Masters of Science in Anesthesiology, followed by the MD, and he got European Diploma of Anaesthesia and Intensive Care. And he is currently working in Ireland in Our Lady of Hospitals, Drogheda. Between Egypt and Ireland, he worked in Saudi Arabia for like maybe 13 years, and he was a former consultant, associate consultant in King Abdullah Medical City in Mecca. So Dr. Tharwat is talking to us today about one of the most important and high-yield topics in critical care, which is you can call it CRIPSI, catheter-related bloodstream infection, catheter-related or CLAPSI, the catheter-related central line associated bloodstream infection. You can find in the literature both nomenclature CLAPSI or CRIPSI. It is one of the causes of the mortality and morbidity in critical care. That's why it is one of the high-yield topics. It's one of the fast hug you're familiar with, so you have to look on the lines on daily basis and see, does the patient need a line? But I think it's more complex than just checking with the line, and there is a full approach to do that, and we will dive today with Dr. Tharwat Isa. Dr. Tharwat, you can please go ahead and share your presentation if you wish.
Yeah.
Thanks.
Thank you, Walid, for the nice introduction, and I'm really delighted today to be among the speakers of the Saving Lives Academy and among our professors and seniors. And I will go straight away for the topic. It is, as Walid mentioned, it's catheter-related bloodstream infection, CRIPSI, or you can just call it CLAPSI, central line associated bloodstream infection. Both are used in the literature. I have nothing to disclose, and I'm gonna highlight the epidemiology and preventive measures because there is robust data that CLAPSI is preventable. So there is a lot of strategies to prevent the CLAPSI in the ICU. And of course, we're going to highlight the management as well. So my sources today is the CDC report and National Healthcare Safety Network report. And as you can see here, this is just from the kitchen of the CDC. It is just released this month. And also the Infectious Disease Society of America latest version of guidelines and its update in 2014, this collaboration between the IDSA and Society of Healthcare Epidemiology of America. So most of the slides here are referenced by these references. Whenever there is another reference, I'm gonna highlight this. So if I asked you guys what is central line according to CDC latest report and the previous report even, they define the central line that it is intravascular catheter that terminates at or close to the heart or in one of the great vessels that's used for infusion, and this is the most important point here, that's used for infusion, withdrawal of blood, or hemodynamic monitoring. So they considered the great vessels that making determination about CLABSI events and counting the central line days, these major vessels, including our commonly known internal jugular subclavian femoral vein. But it is not just these veins. However, the aorta is included, pulmonary artery, suor vena cava, and others. So what is not central line as per CDC and NHS in reporting, they didn't consider, for example, the arterial catheter as a central line. However, in some other research and literature, arterial catheter has the same and equivalent risk of catheter-related bloodstream infection. CDC also introduced the new nomenclatures for CLABSI or CREPSI, that is LCBI, and basically it is LCBI 1, 2, and 3. And we are concerned here for 1 and 2 because 3 is for peds, for pediatrics. So it is a lab confirmed bloodstream infection. And that is when the pathogens, isolated pathogen cultured from one or more blood cultures, which is not related to infection at another site. They quoted this as LCBI1, or lab confirmed bloodstream infection 1. And LCBI2, when at least you have one of symptoms or signs of chills or hypotension or fever. And of course, you should have the pathogen which is not related to infection at another site. And also they introduced the MBI, a lab-confirmed bloodstream infection, that is mucosal barrier injury, which is basically for the patient who is severely immunocompromised, severely neutropenic patients, or post-transplant recipients because of mucosal barrier injury. So IDSA guidelines defines the CLABSI as either one of those definitions. If you have got the same organism cultured from the catheter tab, which is the same organism cultured from the peripheral blood taken at the same time, that is a high quality of evidence to support the diagnosis of CLABSI. Or if you have two blood cultures, one from the catheter hub and one from the peripheral blood, and it meets the quantitative criteria for CLABSI, which is growth threefold and from the catheter hub culture higher than the peripheral blood culture, that's CLABSI, or differential time to positivity. That means the growth in the catheter hub culture 2 hours earlier than the growth from the peripheral blood culture taken at the same time. That is differential time to positivity, denoting there is CLABSI, and it has a high sensitivity and specificity up to 91% for CLABSI. So how large is the CLABSI problem worldwide? According to the report from the WHO and also the systematic review and meta-analysis published in The Lancet, that it is around 12 infections per 1,000 central line days. And it is calculated per 1,000 central line days, and there is a specific equation for that. So it is around 12 infections per 1,000 days. How large is the CLABSI problem in the ICU per 1,000 line days? In different countries between Europe, Australia, and US, it's around 2 to 5%, 2 to 5 episodes each ICU per year. If we translated this to a mortality, it's going to be around 12 to 25%, as per CDC latest report. The mortality attributed to CLABSI is around 12 to 25%. That means 1 death each ICU per year. If we translated this to the cost, it's going to be around $39,000 per episode. And the averted cost, according to the CDC report, is around $40 million per events. Here we have 30 years of evidence that CLABSI is preventable, and it's highlighted in many studies before published in the New England Journal of Medicine, BMG, and also the CCM, and in more collaborative major studies, multi-center one, and this is a report from CDC published in the JAMA in 2006. They have a reduction of 68% in the CLABSI rates in the ICUs during this research when they applied the preventive strategy. So there is a robust data that CLABSI is preventable. That urges the CDC to highlight these preventive strategies, and these strategies are education and training and well staffing of the units, selection of the catheter sites, hand hygiene, patient cleansing, and catheter securement devices, antimicrobials, and antiseptic impregnated catheters, and antibiotic, antiseptic ointment, and anti-lock therapy. So to go faster through these items, and you guys can just have a look on the CDC report, and you go through this in details, because it is very interesting to have these items as a preventive strategy in these units. Educating the staff and periodically assess the knowledge and adherence to the guidelines, and assess the competency of the staff every now and then, and also ensure the appropriate staffing levels in the ICU. Also, in your daily round, you have to evaluate the catheter insertion site daily by palpation through the dressing for any signs of inflammation or discharge. Per evidence, hand hygiene is the single most effective precaution for prevention of infection transmission between patients and healthcare workers. We will try to just be a bit interactive here. I'm going to give you this scenario or question. It is a very short and simple one, just to highlight some issues. You are revising your ICU CVC infection prevention guidelines. Which of the following measures should be included? Is it nasal screening for Staph aureus and decolonization for patients receiving a CVC, or guide wire facilitated replacement of CVC in use for more than 1 week? Preference for the theater over the bedside insertion, or preference for iodine for CVC site skin preparation, or it is removal of the idle CVC? What do you think? I will wait for 30 seconds, Walid.
Yes. Yes, sir. Five more seconds. You have the results now, sir.
Okay, now I have the answers, and yes, 36% of the attendees answered the right answer, which is removal of the idle CVC. We'll go through this in just a couple of minutes. Here, you can see here, this study, a comparison of the efficacy of 3 topical antiseptic solutions for prevention of the catheter colonization. It is an RCT multicenter. The primary outcome was the catheter colonization incidence, and the secondary outcome was the CRIPSI incidence, ICU length of stay, and mortality. And looking at the outcome here or the results in terms of colonization here to the left, and the CRIPSI here to the right, they compared the chlorhexidine 0.5% versus 1% and iodine 10% as antiseptic solution for sterilization during insertion. You can see here, this is the 1% chloroxidine, this is the 0.5%, and here is iodine. Here is the risk, the cumulative risk. It is apparently here that chloroxidine 1% and 0.5% are much better than iodine in terms of colonization, and the p-value is statistically significant. And looking at the CRIPSI, there is almost no statistically significant difference between the three items. So they concluded that chloroxidine is superior to iodine for the prevention of intravascular catheter colonization. That's why it is per guidelines, it is recommended to use chloroxidine over iodine and even alcohol 70%. Here, this is a reduced MRC trial published in the New England Journal. It is a multi-center RCT. They randomized the patients into 3 groups. One group implemented MRC screening and isolation, and the second group is targeted decolonization, screening, isolation, and decolonization using chloroxidine bathing and mopirocin ointment. And the third group is universal decolonization. Without screening, they are doing decolonization for all the patients. And they concluded that universal decolonization was more effective than targeted decolonization or screening and isolation in reducing the rates of MRC isolates and bloodstream infection. But of course, there is concerns regarding the resistance. So in summary of the prevention guidelines, this is what we are using in our units basically is the bundles. And here is the CDC checklist or bundle, and I urge you guys to have a look on this, because it is not only for handling and maintaining the central lines, but also for the proper insertion practice and for the healthcare organization. And this is a well-known bundle to all of us. The hand hygiene is daily audits for the catheter necessity or indication is, do I need the catheter still to be inside my patient or not? And avoid routine central line replacement as an infection control strategy. Use the chloroxidine for skin preparation, and use fall PPEs, maximal barrier precautions, and optimal site selection. That is also added in the CDC guidelines in 2017, the chloroxidine impregnated dressing, and that is based on the SATFAR trial that chloroxidine impregnated dressing has a lower risk of colonization and CLABSI when compared to the usual dressing. One of the interesting improvement projects in this study published from Australia as an intervention in 37 ICUs to reach zero risk CLABSI, and they added 2 bundles, clinician bundle and the patient bundle. Patient bundle, it is the usual bundle, and they just did a little bit adjustment here that there is no multiple buses. And the clinician bundle, they added here that the clinician should undertake competency, and they are monitoring the PPEs and assessing the scrubbing procedures. And what issues affected cooperation of the staff? And I just brought this for you to highlight that sometimes if you are in a place to do this project, you're gonna face these issues. So the initial clinical resistance, and they found that some clinicians are saying that we don't have CLABSI. They are denying that they have CLABSI. And some others said, I don't believe the evidence. And in 4 ICUs, they are not compliant with the PPEs. And some asking for the money. Data collection and reporting, we need money. And some were apathetic, just apathetic. And they overcome this by more senior involvement and more reporting and feedbacks to the units. And how successful was their intervention? Over 1.5 years, 10,500 centrally inserted lines, they succeeded to decrease it by almost 60%. That is from, in 1 year, 3.7 events, and it reached to 1.5 after 1.5 years. with a statistical significance. And the improvement were basically due to increased awareness by the problem, impact, and burden on the units, and increasing compliance with the clinician bundle, and also a better communication between the ICU staff and the infection control personnel. And also the feedback and the continuous reporting and feedback to the staff. And unfortunately and interestingly also, that it is not due to femoral lines or dwell time. So the reduction in the episodes of collapse not related to the femoral lines or dwell time. So which site you should insert your line? That is the answer here from 3 sites trial published in the New England Journal of Medicine. It is an RCT multi-center. They enrolled 3,400 patients almost, and the primary outcome was a composite of CRIPSI and symptomatic DVT. Looking at the results here, this is the percentage of catheter with complications, and here is the mechanical complications including the pneumothorax, and here is the symptomatic DVT and bloodstream infections. So you can see the subclavian has the highest percentage of pneumothorax compared to the infection risk and the thromboembolic episodes. If you look at the femoral here, has the highest risk of infection, the highest risk of DVT or thrombotic complications. And in terms of infection, it's comparable to the internal jugular approach, but it is much higher than the subclavian approach. So as a conclusion, the subclavian vein catheterization was associated with lower risk of bloodstream infection and symptomatic thrombosis and the higher risk of pneumothorax than the internal jugular or femoral vein catheterization. So which site is safe or safest for CVC placement, or what is the ideal site for CVC placement? Bare evidence, there is no ideal position for central venous catheter, and you have to tailor the indication at the bedside case by case scenario. No one size fits all here. So no ideal position for central venous catheterization, and most of the intensivists they found and junior doctors prefer the internal jugular or femoral rather than the subclavian because of the more feared dramatic complication, which is sometimes the blame-laden one, is the pneumothorax. But collapse or DVT is gonna happen over a couple of days, so pneumothorax is for them is catastrophic issue. But pneumothorax, both and pneumothorax or collapse or DVT are both attributed to the mortality. Some practical tips for the prevention of collapse here, and it is not uncommon scenario to face this situation when you have a crashing patient or you are reviewing a patient in the emergency department or even in the unit and the patient's crashing, so you are in hurry to insert the line, so sometimes you are not compliant with the full aseptic technique or the full BBEs. So during emergency situation, the recommendation is to review the catheter and replace it as soon as possible, preferably within 48 hours. And post-insertion, as we have mentioned in the bundle, early removal of the catheter that is not needed. On daily basis, you have to review the indication for the catheter. Do I need the catheter or should I remove it? Where possible, removal of the central line also on discharge from the ICU. The most common pathogens involved in the collapse per this study is the Staph aureus up to 40%, and followed by Pseudomonas and the Candida, almost 15%, followed by the Coons, Acinetobacter, E. coli, Klebsiella, and in some other studies, the Coons comes up to accounts for 37% of the collapse. Some other microbiological consideration for you to know that Stenotrophomonas is prevalent in oncological patients. Bacillus and Corynebacterium are occasional pathogens as well. MDROs, gram-negative bacilli, are of interest concern due to the additional risk of mortality and treatment failure. The fungal infection, specifically the candida, are common in the patients who are getting TBN. And possibly you can find the infection is polymicrobial. And rarely the anaerobes produce collapse. And the burn patients, you have to consider Pseudomonas, and the cancer patients prone to enteric pathogens and gram-negative bacilli due to mucosal barrier injury. And the source of infection is easy. If you have a line in, so you can expect that the source will be contaminated infused or the catheter hub, and you are blamed here for your hand hygiene and barrier precautions, or either contamination or colonization of the skin or hematogenous spread. So if I asked you guys this scenario, 56-year-old male patient with pancreatic cancer, status post-Whipple procedure, has a big line placed in right antecubital fossa and started on TBN. 5 days later, he developed fever of 38.5. You see him and notice that he has a moderately swollen right upper extremity. White cell count is 15,000, and he is hemodynamically stable in the surgical ICU. So what are appropriate next interventions would include? Is it obtaining blood cultures, Doppler ultrasound of the limb, start empiric antibiotics, or pull the big line out, or ask for stat TEE? What do you think? Yes. So we have 38% obtained blood cultures, 22% Doppler. I lost the answers. Okay. Okay. And why not starting antibiotics? It's only 11%. Okay. So do you agree that it is interventions? It is not single best answer. So yes, you're gonna do obtain the blood cultures. You should start the antibiotics and write down the order for Doppler ultrasound. So if I asked you again, what antibiotics should you start here to cover? Is it the gram-positive cocci, or to cover the yeast, or gram-negative bacilli, or the anaerobes? And this is the scenario again. Yes, perfect. So 44% agreed that it is gram-positive cocci coverage, and this is right, because this is evidence is the most common causative pathogen for collapse in such patients. You might consider later on yeast and gram-negative bacilli, because the patient basically in ICU and he is on TBN. So you might consider yeast, but later on, but empirically and first choice, you should cover the gram-positive cocci, and that's right. So clinical manifestations for collapse, you should suspect when fever or bloodstream infection occurs in the setting of CVC without apparent source. You don't have other source, and you have a line in, and you have fever or signs and symptoms of bloodstream infection. Other manifestations including if you have inflammation or purulent discharge at the site of infection, and that is easy to recognize, or the catheter dysfunction, or signs of sepsis after infusion, and bloodstream complications like infective endocarditis, osteomyelitis, or metastatic infections or thrombophlebitis. And here's some microbiological tips and tricks for the assessment. In terms of blood cultures, and it's very critical to have a blood culture in a proper way, because the catheter cultures have a higher false positive rather than the peripheral one, and the contamination rate is very high. So you have to obtain a paired blood cultures from the catheter and from the peripheral vein at the same time, and use the same volume of blood for each, because positivity is related to the volume of the blood obtained. And you should clean the catheter hub to avoid contamination with either of the antiseptics available to you. And label the bottles to reflect the collection site, because this is very important for the diagnosis, as we have mentioned that you have to have the same growth from the peripheral blood culture and from the catheter hub at the same time. And the catheter cultures have, as we mentioned, higher false positive rather than the peripheral ones. Both types of cultures have excellent negative predictive value. Some centers are using dedicated phlebotomy teams, and it is proven to reduce the contamination rates, especially with the skin preparation. What about the single positive blood culture for cones? And this is also not an uncommon scenario to have one culture which is positive for cones. Cones here is the coagulase negative staph aureus, or coagulase negative staph. Usually it is a contaminant, and it is advised to repeat the blood cultures. Obtain the blood culture from both suspected catheter and the peripheral site if possible. Removal of the catheter, it is a matter of controversy, so it is a risk-benefit ratio, and you might consider the antibiotic lock therapy in this situation. For the catheter tip culture, shall I culture the tip of the catheter anytime I'm removing it? The answer simply is no. It should be performed upon catheter removal when the infection is suspected. But for routine culture of the tip, it is not advised or not recommended per guidelines. Consider culturing the intradermal part if the age of the catheter less than 10 days old, and the catheter tip if it is more than 10 days old. That's for short-term catheters. For the tunneled catheters, culture the tip at any age. And the diagnostic criteria here is semi-quantitative or quantitative as per microbiological criteria. If you have any exudate at the site of insertion, always swab it and culture it. Don't treat positive catheter tip cultures in absence of bacteremia except for Staph aureus. The key treatment decisions based on the antimicrobials, duration of treatment, antibiotic lock therapy, and the use of echocardiogram. What are the indications for that? Should I remove my catheter or not? And the reinsertion timing. Starting with this scenario, again, we have 66-year-old patient who has diabetes, hypertension, depression. He has anaphylaxis to cephalosporins and vancomycin. He's admitted to the ICU after a motor vehicle accident. After 2 weeks, developed fever of 39 degrees centigrade. He is getting fentanyl, tramadol, citalopram, and trazodone, and white cell count of 2,000 only, hemoglobin 7.4, platelet count 60,000, and the cultures from CVC and peripheral blood show rapid growth of gram-positive cocci clusters. Chest X-ray, no infiltrates, no pneumonia, and it has a right IG catheter in place and tracheostomy. Direct molecular assay revealed MRSA, and the sensitivity testing is pending. After removing the central line, which antimicrobial is your best choice here? What do you think? Is it the linezolid, Is it the piperacillin tazobactam, or meropenem, or daptomycin, or vancomycin? Okay, so I have here meropenem 34% of the attendees, and 34% equivalent to linezolid, and 7% to daptomycin, and 17% to vancomycin. Oh, shocking. Okay, so you guys have a look here again, please. He has anaphylaxis to cephalosporin and vancomycin, so vancomycin is not your choice here at all. So the answer here is daptomycin. And why that? Vancomycin should be basically is your first choice because it is MRSA, but the patient has anaphylaxis to vancomycin. So you should have an alternative to vancomycin. Linezolid is not a proper choice here because the patient has pancytopenia including thrombocytopenia, and linezolid will further deteriorate this platelet count. It's one of the side effects of linezolid, so it is not your proper choice here. In addition to is getting SSRI, so it is not the proper choice. And biptaz and meropenem are not good choices for MRSA, so you are left with daptomycin. And basically, per guidelines here, vancomycin should be your first choice as initial therapy for MRSA and Coons, if it is prevalent in your unit. If you don't have the choice for vancomycin, second choice will be daptomycin. Linezolid shouldn't be used for empirical therapy at all, per evidence. And also, linezolid is not FDA approved for bacteremia, by the way. Gram-negative bacilli coverage, it is something like politics. You cannot say, I'm gonna use meropenem or biptaz or whatever. It's something like politics because it is based on the local decision. What I'm treating nowadays in my unit with augmentin, I was treating with meropenem 2 grams Q8 hours plus colistin in my previous institute. So it is something based on the local susceptibility data and the severity of the illness, antibiogram, and so. To cover MDROs, usually in neutropenic patients, you have to use a combination. Those patients are kind of very ill patients, or the patient is colonized. You have to look for the history of colonization of your patient. If the patient has a history of Klebsiella, for example, so you have to consider the coverage of Klebsiella. The femoral catheters in critically ill patients, you have to cover gram-negative bacilli and candida as well. Other indications to cover candida if the patient has sepsis and is getting TBN, if the patient has broad-spectrum antibiotics in the previous days, or hematological malignancy, or transplant, or the patient is colonized in multiple sites with candida. Candida coverage, usually your first choice here is the echinocandins. You can use the azoles, yes. If there is no azoles for the previous 3 months, or very low risk of Candida krusei and Gillibrata. In deciding whether to give 2 rather than 4 to 6 weeks, this is based on the duration of antimicrobial therapy. So if you are deciding whether to give 2 weeks rather than 4 to 6 weeks antibiotic treatment to patient with Staph aureus for a removed CVC, all of the following are important to consideration, except a negative TEE at 5 to 7 days after onset of bacteremia, or history of aortic graft placed 2 months previously, what the ID consultant recommends, or whether the catheter tip culture had more than 100 colony-forming units of Staph aureus, or resolution of fever and bacteremia within 72 hours of initiation of appropriate therapy. What do you think? Okay, so I have 27% of the answers what the ID consults recommends, and whether 14% only whether CVC tip culture had more than 100 colonies. Okay, so the answer is number 4. And looking at here for the guidelines, Staph aureus, generally this is one of the sticky bugs. You have to remove the line. So generally remove the castor, and generally speaking, you have to treat for 4 to 6 weeks. Except for certain situations, short course, if the castor removed and the patient non-diabetic, non-immunocompromised, no hardware, negative TE for infective endocarditis, fever and bloodstream infection resolved within 72 hours of initiation of appropriate antimicrobial therapy, and no symptom signs of metastatic infections. So in this situation, you can give for a course of 2 weeks. If positive culture castor tip, but negative peripheral blood culture, 5 to 7 day course systemic antibiotics with careful follow-up. You should follow up your patient on daily basis. TE recommended, and it's better recommended to be done 5 to 7 days to increase its sensitivity after 5 to 7 days from the onset of bacteremia, and hematogenous complications in case of Staph aureus, like infective endocarditis, might prolong the therapy up to 6 weeks. In case of Crohn's, coagulase negative staph, it's one of the most common organisms in CLABSI, and it's difficult to distinguish true pathogens versus contaminants, and the likelihood increases with isolation from multiple sites. The treatment options here is the castor removal, or give antibiotics for 5 to 7 days if the castor removed. If you want to salvage the castor, you can give up to 14 days and also use adjunctively antibiotic lock therapy. In case of endocarditis, it's extended to be 6 weeks. Other pathogens like enterococci or gram-negative bacilli up to 14 days, and the candida 14 days post-negative, the first negative culture, it is up to 4 to 6 weeks, sometimes in persistent fungemia, and antibiotic lock therapy for castor salvage, and the recommendation is to use the relock therapy, the antibiotics, every 24 to 48 hours. Whom you're gonna call? The ID consultant, and in this study, the mortality here, this is the proportion of survival, and you can see the mortality benefit when you are contacting your ID consultant or the microbiologist. So it is recommended by evidence. The echocardiography guidelines here, the timing, as we mentioned, just wait for 5 to 7 days from the onset of bacteremia to avoid false negative results, because you might need to repeat it if it is the first one is negative and still you have persistent bacteremia or fever specifically after castor removal. Transthoracic echo is inadequate to exclude endocarditis, and you have to go for TEE. If you want to use the short course of antimicrobials for Staph aureus, you have to do TEE as well. Some other pathogens, you have to be guided by the clinical manifestations like new murmur or embolic manifestations, and persistent fever or bloodstream infection, the time you should go for TEE. I think this is the last question. And evaluating CVC in a febrile bacteremic patient, which of the following elements contribute least to decision to remove the castor? Is it the erythema and purulence at the castor site insertion, or femoral versus peripheral vein location of the castor, hemodynamic instability, positive blood culture without focus of infection, a specific pathogen recovered from blood culture? Okay, so this is the right answer. 29% of the attendees answered femoral versus peripheral vein location of the caster, and this is true. So the idea here is where or when to ball or not to ball the central line. So remove the line in the setting of if you have a patient with a central line and he has sepsis, hemodynamic instability, endocarditis or metastatic infections, suburative thrombophlebitis evidenced by erythema or exudate at the site of insertion, or you have persistent bacteremia, that is bloodstream infection more than 72 hours in spite of appropriate antimicrobial therapy. If you have a kind of sticky bugs like Staph aureus, enterococci, gram-negative bacilli, fungi, and mycobacteria, so these are the indications to pull out the line. Guide wire exchange, basically, if you have nothing to do and it is absolutely no alternative sites are available, that time you can exchange the caster over guide wire. And basically, it is strictly prohibited in some centers to do such practice, but in the guidelines, it is mentioned that you can do if absolutely no alternatives. And sometimes we are facing this situation. And in this scenario, culture the old tip and reinsert a new site if the caster tip is positive. You have to be very cautious in this situation. There is no evidence to support the routine exchange of the intravascular caster. I'm coming to the end here. This is a caster infection don'ts. So don't culture the caster tip unless removed for suspected infection. Don't order qualitative caster tip cultures. Always stick with the quantitative ones. Don't underfill the blood culture bottles because positivity rates equals the amount sampled. Don't start antibiotics without culturing blood, peripheral, and catheter. Don't use linezolid for suspected caster-related bloodstream infection. Don't use thrombolytic adjuvantly to the anti-lock therapy. Don't routinely reculture after discontinuation of the therapy, except infected dialysis casters. This is another entity. And finally, don't forget that CLABSI is preventable. And thank you. I can't hear you, Walid.
Sorry, thanks so much for this very comprehensive lecture, Dr. Sarwat. And just, it looks like a logical question. If you can lock your central line with antimicrobials for 48 or 24 hours even, it's either you don't need the central line from the practical point of view, or if you need a central line, you will put another one. So is there a real practical value from locking central line with antimicrobials?
It is actually a debatable area, Walid. There is controversy whether to use anti-lock therapy or not to use anti-lock therapy because of the development of resistance for the microorganisms. But the idea behind is the biofilm formed by the colonization of the bacteria, and you want to break this biofilm by locking the caster for 1 or 2 days and relocking it. So the evidence behind in the guidelines is not quite high, actually. And to the best of my knowledge, the practice is not that common.
Okay, yes, we have an agreement on this one.
Yes.
So while there is more questions coming, I will put the evaluation of Professor Khaled first lecture. So please go ahead and start. You know, that's documentation for attendance, not really an evaluation for the speakers. Our speakers here are like, there's no one beyond the evaluation, but it's just kind of quick assessment. So the first question here by Marwa Hosni Tharwat is, would you please suggest antibiotic lock regimen if there is any?
Yes. There is many regimens basically used for the anti-lock therapy, ranging between the ampicillin, aminoglycosides, specifically the amikacin, and vancomycin, fluoroquinolones, all are used. And this is based basically on the microbiological advice in your unit and the prevalence of the colonization. So there is no definite answer for this. I cannot say use amikacin, I cannot say use vancomycin, because all are studied in the literature and all are effective. That is based on the prevalence of colonization of the pathogens in your unit.
Perfect. Very good. So there's no questions so far. I proceed now to the second poll, which is second assessment for second lecture assessment. Tharwat, another question in my mind. We do always find central line infections or central line related infection is one of the key performance indicators in the unit.
Yes.
And is your unit using mainly the nurses to check for central line infections? Like, is that daily routine, or it is one of our tasks as critical care doctors to assess for that with our daily examination? Is it a nursing job? I know it is the consultant scope of service to assess for that on the term of asking about it, but who is assessing for it practically? Is it the nurses or physicians in the unit?
Basically, we have the bundle, and the compliance with the bundle is strictly monitored by the nurses. In our department here, you have to tick the boxes after inserting the line. You have to write down your name and your ID number so that you can track for traceability of the one who's the operator of this line. So if you're gonna cause CLABSI many times, so you have a problem here. For traceability, they can just acknowledge who is the operator of this line. So this is a nursing issue and in collaboration with the microbiologist and the infection control. But for the doctors, in daily round, it is your duty to have a look on the line and check the indication of the line. Shall I need the line anymore in my patient, or should I take it out? It should be a part of your daily round. So no way, it is shared responsibility. Nurses have their own duty and you have your own duty.
Okay, as per the current evidence, Tharwat, is there any evidence of routine changing of lines if your CRP is getting higher, but like the patient is not febrile, or white cell count is getting higher, or the new temperature? Is there any evidence on routine exchange of your central line without presence of cultures? Is there any evidence on that in the moment?
To the best of my knowledge, Walid, and according to the IDSA guidelines, the routine change of the catheter is not recommended. And it's a quite high level of evidence, basically. But if you have a patient who is febrile and the fever is persistent, and you have the markers, sepsis markers, like you have mentioned, the CRP and white cell count is going up, and you don't have any other source for infection, so that raises the possibility of CLABSI, and this is the time you have to think in removing the line from a practical point of view. It depends on the clinical scenario of the patient, but sometimes you have other source of infection. So if you have another source of infection, send the cultures, send the hub, the culture, blood culture from the catheter hub and the peripheral blood culture, and see the catheter is blamed or not. If you don't have any other source of infection, that mandates to remove the line.
So it's an area of common sense rather than real guidelines. Yes. So like I faced that in Ireland myself. When I came here, I found there is a routine change of central line after 5 or 6 days. If there is no other obvious source, if you don't have any other source of infection, you take the cultures, and if you still suspect the central line is your source of infection, get the benefit of doubt and change it. This is a common practice, which I find it's like a common sense, despite it's not present in any literature or any guidelines. Do you agree with that, Tharwat?
Yes, I totally agree. I know they like that so much. And also in my previous institutes in KCA, whenever you have the suspicion, take the line out. It is very easy to pull the line and take it out. But basically, I am a fan of resistance in this situation. If I have a line in place and there is no local signs of inflammation, and I have another source of infection, so shall I go and to take the line out? And it is not that easy issue to take the line out and introduce another one. Sometimes it is a challenging situation, and the complications are still there. You might cause pneumothorax, or you might cause another collapse yourself. So it is not that easy, and most of our patients are coagulopathic, and the situation, I mean, is challenging to insert a new line. So you have to assess the situation thoroughly, not just take the line out. Yes, okay, take the line out. So you have to judge the situation and see the correct decision or the optimal decision or not.
Okay, so I can say that we have no more questions from attendees. Let me have a look here. Yes, should the antibiotic lock include antifungal in immunocompromised, or antifungal just kept for treatment of proven infections?
For using the antifungal, I don't know, but the anti-lock therapy is used in the guidelines for catheter salvage mainly. If you have no choice and you have to keep the catheter in, and you have a proven catheter bloodstream infection, the time you have to give the systemic antibiotics for 14 days, in addition to the antibiotic lock therapy. But the antifungal, I don't know. I have no idea.
Perfect. Okay. So any questions from Prof. Khaled, Dr. Yasser Zaghloul, Prof. Nabil, Dr. Hazem, our panelists here? Is there any burning questions or anything adds to this discussion? You're always welcome to unmute yourself. Please feel free to ask if you have any questions.
Thank you very much. Really, it's been a very nice lecture about the catheter-related infections. Yeah, I want just to ask one question. What is the incidence of fungal infections in your ICU?
In our ICU, it's around 10 to 15%, I could say. So
it's it's fine.
Yeah.
Yeah. And what's your preferable antifungal drug? Do you use echinocandins or sorry?
No, the azoles, fluconazole. Here I have met different antibiograms. What we are treating before in my previous institute was carbabinums as initial therapy. We are treating here with augmented. So you can imagine that we are treating ventilator-associated pneumonia and hospital-acquired pneumonia with augmentin, and the patients are recovering. In some other institutes, we are giving meropenem and colistin and a lot of antibiotics for the patient to recover. So our first choice is fluconazole, basically. Then we are escalating according to the daily review and the response of the patient, and basically according to the culture and sensitivity to either echinocandins or ambizone.
Okay.
Yeah.
And your echinocandins is what? You're using anadilofungin or?
Caspofungin and andulafungin.
Okay.
Yeah.
Well done.
Okay, so thanks very much, Dr. Sarwat. Thanks very much, Prof. Khaled. And our apologies from Dr. Magdi Khalil. He had to leave a bit early, so he's sending you his apologies as he had to leave a little bit early. So see you in the last session next Saturday, and the 30th session on Anaesthesia and Critical Care refresher course. Another reminder with International Research Symposium on 16th of January. Prof. Nabil, how are you? Our regards from the whole family of Anaesthesia and Critical Care refresher course. So thanks so much everyone here tonight, and see you in the last session.
اهلا ازي صاحبك، كل سنه وانتم طيبين.
اهلا وسهلا
بحضرتك يا فندم. الحمد لله تمام، وحشنا جدا. الله يخليك، وحضرتك بالصحه والسلامه.
I'm delighted to have this team here in the new year, and see you all next week, inshallah. Last session, please be there. There's a lot of surprises next week, inshallah.